Will you proceed for the second slide? Yeah, good morning, dear friends. First of all, I'm thankful to the organizers for inviting we, the endocrinologist, to participate in this ISLTS. I'm given a very big topic of hypocalcemia, and it's very, very difficult to cover, even salient points in 10 minutes. So I would try to justify. Uh, See, hypocalcemia is one of the commonest endocrine problems, but one of the dreadest endocrine complications which we come across is hypocalcemia post-operatively, post-thyroidectomy, and uh, parathyroidectomy along with thyroid surgery. We must know the values because the many guidelines they suggest in millimoles. So uh, these are the mild or moderate or severe calcium levels, and we not only physicians but also surgeons will know what are the normal values. See, hypocalcemia is not a very benign condition, and particularly in the setup of post-operative condition, it can be very, very, difficult, and also it can be very serious complications. We know the paresthesia and other tingling, numbness as, symptoms of hypocalcemia, but they can be as grave as cardiac and neurological problem, and there can be not only severe morbidity and at times mortality. So this has to be taken very seriously, and it is not a very uncommon problem. So hypocalcemia, as such, is very common in our countries because of several reasons, nutritional reasons, and diverse disorders, and particularly due to rampant vitamin D deficiency. So patients are already predisposed to have, hypocalcemia post surgery for hyperparathyroidism or even for thyroid surgery. So what happens and what are the chances of, or incidence after thyroidectomy uh, for or parathyroidectomy? This elegant study which was done in south of our country in Trivandrum, 20%, roughly 1 out of 5 patients post thyroidectomy or parathyroidectomy, they develop hypocalcemia. It's a huge 1 out of 5 patients developing hypocalcemia. And the regions may be because of removal of the glands or because of vascular insufficiency which is happening during surgery. So problem is very common. 1 out of 5 patients developing hypocalcemia, even moderate or severe, you know what one has to do to handle them. So there are severity, risk stratification. There are high risk patient groups, and we need to find out who are more vulnerable. So these are the high risk patient groups which are already vitamin D deficient to begin with, elderly people, patients having renal problems, and this EVOLVE trial which was done in renal patients, it was found that patients with CKD, they are more vulnerable to develop hypocalcemia. So all these needs a meticulous pre-operative management or diagnosis and evaluation before we subject this patient for surgery. What are the predictors for developing hypocalcemia? Then there are, this has been studied and it was found that patients who are having high serum alkaline phosphatase indicating vitamin D deficiency to begin with, patients having low serum calcium before surgery, patients having high plasma PTH, which indirectly reflects vitamin D deficiency, and then there are geographical variation, and India can be an exception because of rampant vitamin D deficiency. Hungry bone syndrome is a very common condition, and in fact, Akash is sitting here, and we had managed one patient who developed severe hypocalcemia post surgery for hyperparathyroidism, and then she had to manage for this condition for about 4 to 5 days. Required lots of IV calcium, oral calcium, active vitamin D, and then finally, and in spite of the fact that her parathyroid was preserved, she had one classical parathyroid adenoma which was removed, and the other 3 parathyroids were intact. PTH was normal. She developed severe hypocalcemia, which required management for almost a week or so. So, what are the guidelines for managing hypocalcemia in post-thyroidectomy, post-parathyroidectomy subjects? We need to do early detection and monitoring, which is the key thing. If we, if you can prevent, that's the best solutions. And post-thyroidectomy protocol, we need to, measure patients' calcium as early as possible, and we need to supplement calcium as soon as possible. We need to first identify who are most vulnerable patients, and there are the ways how we can manage and find out. This is a very busy slide to understand how it can be managed, which is published by European Thyroid Journal in 2023. We need to see the calcium level, which is mentioned in millimole, less than 1.85 millimole, which is equivalent to about 7 serum calcium 7 milligram per deciliter. So if patient is having hypocalcemic symptoms, we can use calcium gluconate bolus, and we can also start calcium and vitamin D. So the key things in managing hypocalcemia is calcium, vitamin D, active vitamin D, and if needed, IV calcium. So once we achieve eucalcemia or patient becomes symptomatic, we can continue with oral calcium and vitamin D. If patient is asymptomatic, we can just manage with oral calcium and active vitamin D and also vitamin D. If calcium is above 1.85 millimole per liter, if patient is asymptomatic, can be managed through only oral calcium. If symptomatic, we can give short dose of IV calcium, so on and so forth. So these are the guidelines by American Thyroid Association, which says which are the patients who can be vulnerable and how it should be managed. So first, conduct surgery so as to avoid removal or devascularization of parathyroid tissue. Try to preserve parathyroid, and this is the role of parathyroid surgeons. In case it is damaged, or you can still do autotransplant. And patients who are at risk, they should be managed before surgery. We need to titrate calcium with or without calcitriol. And calcitriol, it works just like parathormones, and mechanism of actions are almost same. So giving good amount of calcium and calcitriol can maintain eucalcemia, and there needs to be a good communication by physicians and also lab people so that they can be managed in a better way. And try to avoid or create hypoparathyroidism, because hypoparathyroidism lifelong is the worst complications. It's very costly, and also patient has to pay the entire life, and there are also some emergencies which one has to face. Now, approaches to management of post-operative hypoparathyroidism. If you need to have empiric prophylaxis, there is a huge pull of calcium. So even if you give oral calcium with normal calcium level, still there won't be any problem. So some of the patients or most of the patients can be given empiric prophylaxis. If there is mild to moderate hypoparathyroidism, you should give calcium, and also you should give calcitriol. And if there is a progressive or symptomatic hypocalcemia, one should give calcium 3 to 4 gram daily. People are still worried about giving calciums, and when we prescribe 6, 8, 10 or 12 tablets of given calcium, even physicians, they are extremely worried, and they are not ready to start. But this is life-saving, and one has to do it. IV calcium is of course for emergency, but we cannot give indefinitely, and we have to give simultaneously oral and calcium and vitamin D so that we can discontinue IV calcium as soon as possible. So there can be mild hypocalcemia, which can be managed with oral calciums. Then can be severe hypocalcemia, which requires calcium. IV calcium gluconate is the drug of choice. We can use calcium chloride, but there can be side effects, local as well as systemic. But we should not give indefinitely IV calcium so as to, that prevent your phenomenon. Chronic hypocalcemia can be best managed by endocrinologist or good physician who knows the subject. And now the newer parathyroid hormones are available to treat hypocalcemia following hypoparathyroidism. Although it's a difficult thing, it's an expensive thing, but still, if you are struggling to manage, this can be a good patch for a shorter time. But long-term parathyroid hormone can be a very costly affair. So there are benefits and limitations of parathormones, but person can use if there is lots of variations in calcium level post-operative. So this meta-analysis suggests what are the best options to treat hypocalcemia post-operative, and they found that teriparatide is a very good option to prevent variations, but oral calcium, vitamin D3, or maybe intravenous calcium. But best thing what we do in our practice, for example, SVP hospital or other hospitals, give good calcium, good active vitamin D, good baseline vitamin D, and just add IV calcium if needed. So innovations in therapy, newer PTH analogs are available, and now this peloperi, it's a difficult name to pronounce, pelopegritriparatide. This is a long-acting PTH, and it can be also useful. You can give once in 3-4 days, but this is not a very good molecule to choose because it's very costly, and it can be used for only very select population. So to conclude my talk, we need to identify patients who are vulnerable, and we should have good risk stratification just before offering patient for surgery. And secondly, we need to find the vulnerable groups, and we need to see the prevalence, which can be higher in certain groups. And calcium and PTH therapies are very easily available, and we should, confine mainly to calcium, vitamin D, and active vitamin D, and SOS, PTH, teriparatide, or the newer molecules. And we need to have individualized monitoring and care. So lastly, I would like to conclude that parathyroid problems have increased enormously, but to have hypocalcemia post-operative can be a very, very difficult situation. And best thing is to involve parathyroidologists or endocrinologists right from the beginning to avoid this complication. And lastly, you must try to avoid hypoparathyroidism permanently because it can be a much dreaded than hyperparathyroidism.